All right, so now we're going to be going through a couple of cases on contraceptive management. And I just wanted to pause here and make a recommendation about how to do these cases. So they all start with a prompt. And what I'm going to recommend is that you pause the video, then think about what your answer would actually be, and then listen to the explanation, just because we know that the more that we can ask you to retrieve the information and to engage with the video, the better you will learn the material. I want to make sure that the time you're spending watching the video is as effective as possible for your learning. All right, so let's start with a 32-year-old woman. She has a history of trich 3 months ago. She received treatment and that has resolved. And she tells me that she just doesn't want to be pregnant right now. So the question is, what is the best options for her if her primary goal from her contraceptive method is to prevent pregnancy? So I think many of you may already know this, but it's still so important that it's worth going over again. So how well does birth control work? I think about birth control in 3 tiers. So the 5-star really, really well birth control forms are Nexplanon or the implant. IUDs, including copper IUDs that don't have hormones, as well as levonorgestrel IUDs like the Mirena, Skyla, Liletta, Kylena, and then surgical sterilization, which is an option for both men and women and is permanent. For all of these highly effective forms of birth control, about 0.1 to 0.8% of women become pregnant in any given year. So less than 1 in 100 women will become pregnant using one of these forms of birth control. The moderately effective forms of birth control include combined oral contraceptive pills, progesterone-only contraceptive pills, patches, rings, and the shot like Depo-Provera. And 6 to 9 in 100 women with typical use will become pregnant using these methods, depending on the method and how closely they're able to adhere to the birth control formulation. And then finally, the less effective forms of birth control include things like pulling out, fertility awareness, and barrier methods like diaphragms, male and female condoms, where 12 to 24 in 100 women become pregnant in a given year using this method. It's really important to note, though, that even these quote-unquote less effective methods are more effective than nothing at all. Without any form of contraception, about 85% of women will become pregnant in any given year if they are heterosexually active. So while I think that a person who is primarily interested in preventing pregnancy should choose a highly effective form of birth control, I do want to be clear that these other forms of birth control, including barrier methods, have some advantages that the more effective forms don't have, like STI protection, and that they are better than nothing at all. For our patient who says that her primary goal with birth control is to not get pregnant right now, I think we should be looking at these really, really well orange, highly effective forms of birth control. Let's start with the IUDs. Like we talked about, there are hormonal and non-hormonal IUDs. One of the questions that often comes up is whether an IUD is a reasonable option for this particular patient, given that she has a history of cervicitis. The answer to that is yes. As long as she does not have active mucopurulent cervicitis, it is okay to start her on it with an IUD. Overall, IUDs are very safe. There's about a 0.01% risk of uterine perforation during insertion, but globally, the risks are very, very low. And about 0.1% of people become pregnant in the first year using hormonal IUDs, and about 0.8% of people become pregnant in the first year using copper IUDs. Another highly effective form of birth control would be the subdermal implant or Nexplanon. Again, it's a very safe form of contraception. There's about a 1% risk with insertion and a 1.7% risk with removal. And the risks there are things like hematomas and infection, so any complication of the procedure. Again, subdermal implants are extremely effective. 0.1% of people who use Nexplanon become pregnant in the first year of use. We think that Nexplanon is one of the most effective forms of contraception that we have. The best recommendations for this patient would be some form of a LARC or long-acting reversible contraception, including a copper IUD, a levonorgestrel IUD, or Nexplanon birth control implant. Okay, let's move on to our next patient. This is a 46-year-old woman. She has a history of stage 1 breast cancer, status post-lumpectomy. She was diagnosed at age 42, and she has a new sexual partner. And she tells you that her primary worry is that she doesn't want to be pregnant, and she just is worried about getting breast cancer again. So the question really becomes, what forms of birth control can this woman who has a personal history of breast cancer safely use? The short answer is that she needs to have a non-hormonal form of birth control. It doesn't matter what age she had breast cancer at, it doesn't matter what stage of breast cancer she had, and her receptor status doesn't matter. It doesn't matter if she was estrogen and progesterone receptor negative. We still don't recommend hormonal birth control in patients with a history of breast cancer. And this goes for any hormones. So it's not okay to give this person estrogen, and it's not okay to give her progesterone. I've included information from the CDC MEC here because I think it does a really nice job of summarizing for us what is considered okay. So level 4 means it is contraindicated, and level 3 is also in sort of the red zone, meaning that the risks probably outweigh the benefits. So what we can see is that for patients who have a history of breast cancer, either current or past, all hormonal forms of contraception are either level 3 or level 4, and we should think about other forms of contraception that this patient can use. So I do want to talk a little bit about women who have a family history of breast cancer. This isn't relevant to a patient that I presented here because she has a personal history of breast cancer, but it is certainly true that I have a lot of women coming to me asking questions about their risk for breast cancer and how it might interact with combined oral contraceptives or any form of hormonal contraception. We do think that there is a very small increased risk of breast cancer among women who are on any form of hormonal contraception. That risk is about 1.2 or 20% higher among those on hormonal birth control, including progesterone-only pills and levonorgestrel IUDs. Based on a 2017 study, there were 13 extra diagnoses per 100,000 women years. But it's important to know that in young women, so women under 35, there were only 2 extra breast cancer diagnoses per 100,000 women years on hormonal birth control. It's also really important to recognize that hormonal birth control is not homogeneous in terms of cancer risk. So while we do think that hormonal birth control may increase the risk of breast cancer, it's been shown to decrease the risk of other forms of cancer, including colorectal cancer, endometrial cancer, and ovarian cancer. Because of this information, the small absolute increase in risk for breast cancer and the decrease in the risk for other forms of cancer, the CDC says that hormonal contraception is okay in women who have a family history of breast cancer. And obviously it's okay in average risk women. Okay, moving back to our patient, the 46-year-old woman with a personal history of breast cancer who can't be on any form of hormonal contraception. I do want to mention that sterilization for her would also be an option. We should view sterilization as permanent. How permanent it is depends a little bit on the method. There is a push to perform more salpingectomies where they remove the entire fallopian tube. That is an absolutely permanent form of sterilization, but no woman should approach a tubal ligation or a vasectomy as a potentially reversible form of contraception. It's not. We look at these as permanent forms of contraception. Sterilization is effective. It's about as effective as our long-acting reversible contraceptive methods, with a failure rate of about 0 to 0.5% per year. And it's one of the methods of contraception that men can control as well. So men can receive vasectomies. Female sterilization, we talked about, can involve tubal ligation. It can also involve complete salpingectomy. It's worth noting here that male sterilization does have a delay in terms of its efficacy. So couples should not think that they have effective contraception until 3 months after the procedure, when the man can submit another semen sample to ensure that the sperm counts have gone down. I also wanted to acknowledge here again that barrier methods are non-hormonal and would be an option for this patient. They're relatively effective. There's about 13 failures per 100 heterosexually active couples. The advantages of condoms include that they're over the counter, they're cheap, they come in many forms, they can be latex, natural, or synthetic, and male condoms, unlike all other forms of contraception that we've discussed so far, also confer some degree of sexually transmitted infection protection. So coming back to our patient who has a personal history of breast cancer and is really worried about her risk of breast cancer, her recommended forms of contraception would be non-hormonal. So that's things like the copper IUD and sterilization for highly effective forms of contraception. And then barrier methods are also an option. All right, our next case is a 22-year-old woman. She has no past medical history, and she tells us, I don't know if I want to have kids, but I don't want to have to think about birth control for a while. And that brings up the question for me, how long do the different methods last? Okay, so here's where I want you to pause the video and think to yourself, how long does a copper IUD last? How long do levonorgestrel IUDs last? How long does the Nexplanon implant last? So contraception duration is different depending on method. So the copper IUD is FDA approved for up to 10 years at a time. There is a new meta-analysis that was published in January 2020 that showed that extended use for up to 12 years wasn't associated with an increased risk of pregnancy. But it's important to know that women who are in their 11th or 12th year with their copper IUD are using the copper IUD in a non-FDA approved off-label way. The duration of levonorgestrel IUDs depends a little bit on the dose of levonorgestrel that the IUD contains. So Liletta, Mirena, and Kylena have different FDA approvals. Liletta and Mirena are FDA approved for up to 5 years. Very recently, Liletta was approved for up to 6 years of use. And again, in that 2020 meta-analysis, there is some data to suggest that all of these forms of levonorgestrel IUD probably work for 2 additional years, so up to 7 years. But again, that's off-label. Only the Liletta IUD is approved for 6 years. Skyla, which is a low-dose levonorgestrel IUD, is approved for up to 3 years. Nexplanon, which is that etonorgestrel implant, also works for up to 3 years, and Depo or DMPA works for 12 weeks, and then the patient has to come back for another Depo injection. It's worth noting that these are the longest duration of use. A woman doesn't have to commit to not getting pregnant for 10 years to get a copper IUD, for example. We can remove these forms of contraception at any time. All right. So next case for us is a 29-year-old woman. She's hoping to start trying to conceive in about 8 months. And she says, I can't wait to be a mom, but not until after my medical residency. And so she, again, is thinking about avoiding pregnancy for a short period of time, but she is hoping to become pregnant within the next year. So that raises the question, how quickly can women expect a return to fertility after they stop using their chosen form of contraception? Let's talk about IUDs. We think that IUDs work primarily by causing irritation, and in the hormonal IUDs by the formation of a mucus plug at the cervical os that prevents sperm from getting into the upper genitourinary tract and fertilizing the egg. That means that IUDs, we think, start working right away as soon as they're removed. That being said, that removal is provider dependent. So a woman can't just decide that she doesn't want to have her IUD in right now and become pregnant. Nexplanon is similar. We think that women should expect a return to fertility within about 2 weeks, but again, you need a provider visit. Oral contraceptives, also, we expect return to fertility within about 2 weeks. And the advantage of oral contraceptive pills is that the woman can just stop them whenever she wants. She doesn't need to make an appointment or come in for a visit. And finally, I wanted to mention that Depo would be a really poor choice for this patient who's hoping to conceive in 8 months. On average, the return to fertility after Depo-Provera is 10 months, and it can take as long as 18 months for women to see a return to fertility after their last Depo shot. I put in here the caveat that that doesn't mean you can get one Depo shot and not have to get another Depo shot for 10 months. Unfortunately, we can see unintended pregnancies in patients who are late to their depot shots. Depot needs to be injected every 12 weeks. But in patients who are planning to become pregnant relatively soon in the next year, I don't recommend depot because it also is associated with a delayed return to fertility. All right, let's move on to our 27-year-old woman here. She has a history of post-op DVT back when she was 22, and she tells me that she doesn't want to be pregnant and she doesn't want anything foreign in her body. All right, let's talk a little bit about estrogen now and some of the comorbidities that I think about before I prescribe someone an estrogen-containing form of birth control. When I am thinking about starting someone on a form of birth control that includes estrogen, I ask about migraine with aura because migraine with aura is associated with an increased risk for stroke in patients on estrogen-containing birth control methods and shouldn't be prescribed in patients with a history of migraine with aura. We already talked a little bit about how a personal history of breast cancer is a contraindication to any form of hormonal contraception. We also should be thinking and asking about a history of DVT or PE, and also patients who are at a high risk for DVT or PE. The reason that we don't prescribe combined contraceptive pills or any form of estrogen-containing birth control to women immediately postpartum is that women immediately postpartum are at higher risk for DVT and PE. For this patient in particular who has a history of a DVT, a personal history of a DVT, she is not a good candidate for any form of birth control that includes estrogen. For the same reason, people who smoke and are greater than 35 years in age are at increased risk of clotting and DVT and shouldn't receive estrogen-containing birth control pills. Similarly, patients who are known to be antiphospholipid antibody positive are at a high risk for clots and shouldn't be prescribed estrogen-containing birth controls. Finally, patients with advanced decompensated cirrhosis shouldn't be prescribed estrogen-containing birth controls. So based on this slide, we know that this patient is not a good candidate for estrogen-containing birth control pills. What about progesterone? Progesterone has fewer contraindications, but there are still a few that I think about. We already talked about how personal history of breast cancer is a contraindication to progesterone-containing birth control pills. Similarly, patients with advanced cirrhosis and antiphospholipid antibody syndrome can't be prescribed progesterone-containing birth control pills. And drospirenone, which is that fourth-generation progesterone that we already talked about, does increase the risk of clotting. That being said, a personal history of DVTs is not a contraindication to progesterone-containing birth control pills. Similarly, depot would be an option for this patient. Depot, like we talked about, is effective. It's in the moderately effective category, but we think it's one of the more moderately effective forms of contraception. Depot can cause some irregular bleeding, some spotting, and after extended use can also lead to amenorrhea. I think it's worth noting here that depot is associated with weight gain. I don't have a case that particularly looks at weight gain. In general, patients who are obese can use any form of birth control that they like, with the possible exception of decreased efficacy for emergency contraception like Plan B that we already discussed earlier in the lecture. Depot is the one exception to that. So women who gain 5% of their body weight during the first 3 to 6 months of depot use are at risk for ongoing weight gain throughout the duration of time when they are on depot. And so I do monitor weight, especially early in the course of using depot for contraception in any given patient. And if I'm noticing significant weight gain on depot, I think about switching to an alternate form of contraception. Progesterone-only pills, like we talked about, would be another option for this patient. They don't involve any kind of foreign material in the body. They're effective, again, in that moderately effective category. There are about 8 to 9 unintended pregnancies per year with typical use. Progesterone-only pills, like other forms of hormonal contraceptive pills, need to be taken daily at the same time every day. Progesterone has a shorter half-life than estrogen, and therefore there's been some thought that progesterone-only pills are less forgiving than estrogen-containing birth control pills, meaning that if you're late with a progesterone-only pill, it is more dangerous than if you're late with an estrogen-containing birth control pill. That hasn't always been borne out in clinical studies, but I usually mention that when I'm counseling patients about progesterone-only pills, that this is a form of birth control where it's super, super important to take it at the same time every day. So to sum up, for this 27-year-old woman with a history of DVTs who doesn't want anything foreign in her body, her best options probably include Depo or progesterone-only pills. All right, now we're going to talk a little bit about menstruation. We've alluded to this a little bit in the conversation around Depo and progesterone-only pills, but I wanted to be explicit. We've paired two different patients for this case. First, we have a 19-year-old woman with a history of painful menstrual periods that are very heavy. Maybe she has some iron deficiency anemia, and she says, I am so tired of these periods. So the question that we're going to ask for her is, what forms of contraception can we use to decrease bleeding for patients who have heavy, painful periods? Her partner in crime for this case is another 19-year-old woman who has no prior medical history, but who tells us that she would really hate it if she had unpredictable periods. All right, let's start with the menorrhagia question. The Mirena IUD or levonorgestrel IUDs decrease bleeding by 71 to 95%. I don't know how that number is calculated. I'm not sure how they measure exactly how much someone bleeds in a given period, but there have been studies that show that the Mirena IUD is similarly effective to some surgical procedures, including uterine ablation, and obviously has the advantage of being reversible. Combined oral contraceptive pills are also considered a first-line option for decreasing bleeding and blood loss. They decrease bleeding by 35 to 69%, and you can use them in specific ways to help decrease bleeding as well. So you can reduce the frequency of bleeding by doing extended cycling so that the woman only has a withdrawal bleed, say 4 times per year, or you can reduce the duration of the withdrawal bleed. So there's nothing magic about 7 days. Sometimes patients who are put on combined oral contraceptive pills for menorrhagia will only take 4 of their placebo pills if they are committed to having a withdrawal bleed every month, and then after 4 days go straight into the active pills again, rather than having 7 days of withdrawal bleeding. Depo is another option for women who have a history of heavy bleeding. It can decrease bleeding by about 50%, and over time, more and more women become amenorrheic with Depo, which also obviously increases, or rather decreases, the blood loss that they experience from their periods. Finally, a note here about copper IUDs. Copper IUDs can make menses heavier and more painful, and so this would be the absolutely wrong thing to use in this particular woman who has a history of heavy, painful menses. Now let's talk a little bit about unscheduled uterine bleeding, or bleeding that occurs outside of normal, predictable cycles. Combined oral contraceptives can cause bleeding and spotting and irregular periods, but that effect tends to decrease once a woman has been on the pill for a longer period of time. So less than 10% of women who are on combined oral contraceptive pills for more than 3 months experience breakthrough bleeding. If they do experience breakthrough bleeding, I look at the dose of estrogen in the combined oral contraceptive pill, and I think about increasing that dose to a medium dose if it's at a low dose. Because remember, low dose estrogen combined oral contraceptives are more likely to lead to breakthrough bleeding than medium dose estrogen. All right, what about progesterone-only pills? About 50% of women on progesterone-only pills will continue to have cyclic menses just like they did prior to taking the pills. About 40% will start having irregular menses, which can be frustrating for some women. And about 10% experience complete amenorrhea on progesterone-only pills. What about the levonorgestrel IUD? I had trouble finding specific statistics, but we do know that amenorrhea is very common, and almost all women will see significant lightening of their periods when they have their levonorgestrel IUDs in place. Remember, the levonorgestrel IUD is one of the most effective options for women who have iron deficiency anemia related to menorrhagia or heavy menses. And so we can anticipate that women who do not want to be amenorrheic will not be happy with a levonorgestrel IUD. Nexplanon is associated with unscheduled bleeding. About 78% of women in any given 3-month period experience some spotting or unscheduled bleeding. It's really important that we counsel women about this side effect before we place the Nexplanon. And one of the most common reasons that women end up having their Nexplanons removed is because they find their irregular bleeding or the unpredictability of bleeding is not tolerable. Finally, let's talk about Depo. So after a year of using Depo, about half of women will be amenorrheic. And as Depo use continues, that number increases. So women who use Depo for 5 consecutive years, about 80% will become amenorrheic. And that means that they may have an unscheduled period here and there, but overall they're not having very many periods. So going back to our patient, the heavy, painful menstrual periods would best be treated with levonorgestrel IUDs, combined oral contraceptive pills, or Depo. And when choosing between these, I would think about need for contraception or need for pregnancy prevention, as well as patient preferences in terms of getting shots or taking pills or having an IUD placed. And for this woman who wants contraception but really values being able to predict when her period is, I would think about combined contraceptive pills. They can be very predictable. And I would also clarify how she feels about amenorrhea. Would she be okay having very light spotting every now and then? If so, I could consider something like a progesterone-only pill or a levonorgestrel IUD or a copper IUD, where she would continue to have her normal cycles. They just might be heavier. But I probably would shy away from something like the Nexplanon for a patient who really couldn't stand not knowing when her period was coming. All right, our last case, I promise. We have a 31-year-old woman. She has a past medical history of migraines without aura, and she is on topiramate. She tells us she doesn't mind taking the pill every day. She's already taking medications every day, and she's interested in contraception. So let's start by reviewing. Estrogen is okay for women who have migraine without aura. So let's talk a little bit about topiramate. Topiramate is teratogenic. It's associated with cleft lip and palate. And we actually prescribe a lot of teratogens, so I always recommend reviewing women's medication lists and thinking about whether medications are teratogenic before I prescribe them to women of reproductive age. Because topiramate is teratogenic, I'm really glad that we're having this conversation with this patient right now about what we can do to prevent pregnancy. I would also add that topiramate interacts with a couple of our commonly used contraceptions. And this is a great opportunity to look at the CDC MEC app to see what the CDC says about patients on topiramate. I have cut and pasted this CDC MEC app for us, and we can see here that certain anticonvulsants, including topiramate, are graded in the red category for progesterone-only pills and combined hormonal contraceptive pills. But we could consider things like copper IUDs, levonorgestrel IUDs, implant or Nexplanon, and Depo. The reason for this is that topiramate can decrease the efficacy of progesterone-only contraceptive pills and combined hormonal contraceptive pills. And these hormonal contraceptives can also decrease the efficacy of topiramate, particularly when it's used for seizure prevention. So for this patient, even though she doesn't mind taking the pill, and even though she doesn't have a history of migraine with aura, because she's had good relief on her topiramate, I would recommend shying away from a combined oral contraceptive pill or a progesterone-only pill. I would think about an IUD for her because she is on a teratogenic medication, and you could consider an implant or Depo as well. So here are my take-home points. We are primary care doctors, and we can prescribe birth control. We can do this even now, because much of this, you'll notice, doesn't depend on the physical exam. It depends on talking to the patient about her values and having an understanding of the patient's past medical history and comorbidities. I open this conversation by asking patients whether they plan to become pregnant in the next year. That is a good way to start a conversation about contraception, and it also gives me important information when I'm thinking about what form of contraception I would recommend. I use the CDC MEC app to help me think about comorbidities and to choose the most appropriate contraceptive method for a particular patient based on her past medical history and comorbidities. I use the Contraception Point of Care app to help me provide counseling to patients about what to do if they miss a pill. The Contraception Point of Care app is also useful for helping me with contraception initiation and for thinking about emergency contraception. Thank you so much for your attention. I hope this was helpful. I acknowledge that it is weird having to watch these lectures at home rather than in a space where you can ask me questions. If you do have any questions about this lecture or about contraception in general, please send me an email or make a comment at the end of the YouTube video, and I will try and respond to your questions quickly. All right. Thanks again for your attention. Bye-bye.